Hi, everyone. Again, my name is Rohit. I'm a first-year resident in the UBC Urology program. I'm here today to talk about serious games in urology, and in particular, focusing on the critical appraisal of various serious game interventions in this domain. I want to thank Dr. Guan as well for his guidance on this presentation. There we go. Let's outline the objectives of this presentation. First, I want to introduce the concept of serious games with some examples and also explain why there's quite a bit of interest in the space. And then I want to talk about the pedagogical principles and the theory about applying serious games in learning. I think that background is going to be important in evaluating at least the face validity of the papers that are going to be coming up. And then I want to explore how people have been applying serious games in urology and in surgery more generally, both in education for not just learners like trainees, but patients as well. When we review the applications of serious games in urology, I'm also hoping to give a better sense of just where the state of the literature is on the topic, and then critically appraise the landscape generally. And then I want to touch on some core principles and important topics in critical appraisal in that process. Other than that, I have no disclosures to make, and I also want to acknowledge that I'm delivering this presentation on the traditional, ancestral, and unceded lands of the Coast Salish, Musqueam, Squamish, and Tsleil-Waututh nations. So what is a serious game? Here we have 4 pictures of very, very different activities, but while all of them are quite different, each of us would probably classify them as games. So for those unfamiliar with the term serious game is any game that the primary purpose, it's not for learning, it's for learning, or it's to convey a message rather than something that the chief mission is just entertainment. But it begs the question, how can any of these games make us better doctors or better urologists in particular? Let's take a couple examples of serious games in healthcare. It would be easy to see how the picture off to the left, for example, would be useful for someone training to be a doctor of some kind. It seems to be this video game simulation of a neonatal resuscitation situation. So it's clear how that would kind of help a student gain some skills and familiarity in that situation. Simulations are often the best way to go about training these halo situations, high acuity, low occurrence situations, and a video game makes for a reasonable simulation. So it's pretty obvious how a serious game works in that setting. But in contrast to that, if we look on the right, we have this Android game called Neon Conduit. And on the face of it, it seems to be a bit of a Guitar Hero clone where you have to move your character around to match up with the lights as they pass through the screen, or you have to laser away all the blocks to clear the screen as fast as possible. And it looks more like a regular video game. It actually looks like it could be fun. But what if I told you, though, that it's actually meant to be a trainer for Greenlight XPS? So this was made by Grendel Games in conjunction with Boston Scientific. And it's made as this fast-paced rhythm game that's supposed to help urologists get acquainted with the core principles for a successful green light procedure. So the core gameplay loop and the movements are distilled down to 4 important aspects of the actual procedure itself, which is tissue fiber distance, sweep speed, sweep angle, and then also managing to control the bleeding. Let's take a couple more examples. Every internal medicine program on the continent holds Jeopardy sessions. I think we would all call Jeopardy a game, although mainly it's mostly a quiz competition. The game part comes from the competition and then the roundabout way in which the questions are presented. But it's fun and people take it seriously, and it does end up being educational. And on the right, I have this citation of a study published in Global Surgical Education where they randomized residents into being put into a weekly leaderboard for their WBAs, which are kind of like EPAs, versus not having any leaderboard. And then there was no change to completing the WBAs otherwise. It was just the leaderboard. That was the intervention. And what they found was that randomizing residents to this group where the completion of EPAs was gamified in this narrow way, it really helped increase EPA completion. So, does that kind of count as a game? The question, what is a game, is very, very philosophical when it comes down to it. Lots of very accomplished people write entire textbooks on the topic. But when it comes down to the purposes of this presentation, I'm kind of going to take a page from Justice Potter and a comment from maybe one of the more well-known Supreme Court rulings. You know what a game is when you see it. So I'd say, like going back to the last example, a WBA completion leaderboard, that's game elements applied to an otherwise normal activity, or in other words, gamifying it. I'd count that as a game. When it comes to appraising serious games in urology, like you will see things that maybe you wouldn't necessarily agree. Hey, that's not very much of a game, and you might be right, but other people might disagree. Serious games applied to healthcare are overall picking up a lot of steam, especially within the last decade. The figure on the left is from a scoping review of the topic, which showcases publication trends using the term serious game. And we noticed a healthy amount of growth of interest, not just in developing serious games, but also studying them more formally. It should be noted, of course, like games precede 1996, but that's around the time that serious games started to enter the vernacular in the space. Before then, they might have just been referred to as educational video game or something different. On the right is a bar graph, which shows the frequency at which US residency programs were involving various types of games into their residency curricula for family medicine and internal medicine programs. And about 200 program directors who ended up responding, 92% were generally in support of using games as an educational strategy, and 80% were already using them in their programs. The vast majority tended to be Jeopardy type games, but others tended to be like more purpose-built teaching tools or review tools, which are again not the high production video games that you might expect coming into like hearing this talk, but they're still games nevertheless. And then also, I would say that neither of these figures really represent the amount of effort and the increasing millions of dollars that and time that goes into developing serious games in healthcare. That data is a bit harder to find, but subjectively, just on a cursory view of the landscape, I think you'll see that the production value of serious games in healthcare is rising just as exponentially. Before jumping into exploring serious games applications in urology, I think it's worth also explaining some of the pedagogical principles underpinning serious games and what might motivate someone to develop a serious game for their students. Knowing these principles, or at least being aware of them, helps us appraise some of the face validity of these games and their utility in actually helping learners in medicine and in urology. And then some of the skills that games can help us develop are maybe a little more obvious than other skills. So, for example, a quiz-themed game can help develop domain-specific knowledge, right, and improve cognitive development in the scientific or technical aspects of our specialty. That makes sense. And as another example, 3D games, for example, often demand a high level of spatial reasoning skills, hand-eye coordination, and how the patient has to perceive and interact with 3D environments. And I think we would all agree that surgery is a 3D space where we use our hands and instruments to interact with our environment and with the patient. And there's obviously a crucial importance to understanding space and anatomical relationships in the OR. So on the face of it, it follows from there too that maybe there's some transfer skills from video game playing to the operating room. Also, depending on the type of game, games also demand a high bar for improving inductive discovery skills and then applying those learnings. For reference, inductive learning, which is also called discovery learning, is a process where the learner discovers rules by observing examples. That's different than deductive learning, where you're given a rule and then you need to apply it. And that can often mirror the cognitive demands of medical practice, where not every rule and not every lesson is given to you explicitly or is written in a textbook. It's learned through exposure and learned through repetition. So even if it's not domain-specific inductions that you're making, you're overall developing a cognitive skill or function or a reasoning skill or a communication skill, things like soft skills that could also transfer over to clinical practice. And dressing up the whole process as a game also takes advantage of the fact that games are meant to be fun, and they take advantage of intrinsic motivations that learners have to engage with fun things, and they're willing to build up their skills autonomously and master challenging situations. So that kind of brings us to the next slide, which is, I talked a lot about what serious games can help us develop, but we should also talk about the opposite. How do we develop a good serious game? I was just talking about the motivations of the player. The user needs to be motivated to play the serious game in order to even access the learning content. Extrinsic motivations and intrinsic motivations have to come together. Extrinsic motivations, I think we're already kind of familiar with this paradigm. They could include simple, concrete things like receiving rewards or coming out on top in a competition. And then the intrinsic motivations arise from ourselves as players, like satisfying our curiosity or wanting to get better just for the sake of getting better at the game or enjoying the game. Ideally, you fulfill both elements. There's a confluence of those motivations. And then when the game is developed itself, there should be a view to maximize the game's learning potential. There's a particular learning framework from this French cognitive neuroscientist, Stanislas Dehaene, which made the four pillars of learning. The four pillars are grabbing at the attention of the learner, engaging them in an active learning process, giving them feedback, and then consolidating what they learned and testing it. And games as a medium, naturally you're supposed to tend to excel at this. Almost every sufficiently developed game demands attention from its players. The core gameplay loop of most games has to force players to become better at the game, and then it rewards them for improving by giving them points or progressing the story or things like that. One especially compelling aspect of using games for learning is how learning can be optimized through entering what this concept or this state called flow. Flow is this state or framework where you're in such deep concentration with all your thoughts and intentions and feelings focused on the same goal. And to achieve that state of flow, learner needs to be engaged in challenging activities that require deep learning and reflection. And if the design of a game is good, then the learner will enjoy playing it, they'll enjoy learning. But if it's too difficult, then the player's just going to be stressed out. Demotivation is going to occur. If the in-game learning tasks are too easy, then the repetition of choice will just result in their boredom. So you need to like straddle that fine line. There's a challenge between, there's a channel between boredom and anxiety, where the engagement with the learning tool is enhanced, and the promise is that learning and retention improve when you're in that state. And the literature in the space is really quite focused on how to exploit and characterize this flow state for learners. The figure on the right is from an article published last year where the authors attempted to use EEG data to dynamically adjust the difficulty for learners in a serious game about reducing plastic pollution in oceans and seeing if that improved learning. And so there's a lot of interest in this space. Anyway, returning back to the development loop, finally, the serious game should be evaluated in order to actually progress towards evidence-based education. The game should be published or at least described in some way, and then ideally be evaluated in a randomized controlled trial with a good comparator and an intelligent choice of outcomes. And that's what we're interested in today. As a spoiler, we'll see that it's very, very hard to choose the best possible outcome in any study on this topic. The best possible outcome generally being long-term information and skills retention, improved clinical outcomes. We're essentially never going to see that, but we'll take a look. As to who the intended audience is, it should be noted that the target for serious games can be anybody involved in the healthcare process, and we'll get to touch on all of these target audiences in the course of this presentation. For trainees and learners more broadly, which is everyone in this virtual room, we can develop our domain knowledge, hard physical skills like surgical skills, and our soft skills like communication skills. Medical students, non-MD staff, residents, and so on. And patients too also have a lot to gain, and a good portion of literature in serious games in urology focuses on how serious games can help adults and children adhere better to the recommended therapies, motivate them, help them make better informed decisions about treatment options, things like that. So first up, we'll be taking a look at a conventional game a gamified spaced recognition situation for helping staff and residents continue their urological medical education. So yeah, the first article we'll study is more of again a gamification of a spaced education quiz rather than a big new video game. So this article is called an online spaced education game for global continuing medical education randomized controlled trial. It's from an author named Price Kerfoot out of Harvard, who's quite active in the space of gamified education. And he conducted the study for urologists around the globe. So it's actually quite urology specific. In this game, what they did was they had a list of 40 multiple choice questions and explanations, all on urology related clinical guidelines. And they enrolled nearly 1,500 practicing urologists, and they randomized them into two cohorts. There was cohort A, who were emailed 2 questions every 2 days, and then cohort B, who were emailed 4 questions every 4 days. And the questions had what they call these adaptive game mechanics to help engage the learners more. So what they would do is they would resend the questions in 12 days if you got it wrong and give you the chance to do it again. And they would resend it in 24 days if you got it right. And if you got it right twice, the question was retired, so you completed it successfully. And if you didn't answer at all or you got it wrong, again, then the question was expired. The other main gamified aspect was that there was a bit of a leaderboard. They fostered competition by posting relative performance among urologists. All the questions were taken from AUA clinical practice guidelines in 5 topic areas: hematuria, priapism, staghorn calculi, infertility, antibiotic prophylaxis. And the main outcome measures were the baseline score, which was the percentage of the questions that were answered correctly when they were shown for the very first time, and the completion scores, which was a percentage of the questions that were successfully retired. And then all the staff that participated, they all got a CME credit incentive as well. The study is interesting because outside of the primary outcome being the baseline and completion score improvement, the study dropout itself is actually a rather pragmatic in this regard. It's a metric of learner engagement, so it's quite nice. The main things to highlight from their results section was that in their study flow, the Q2 days study group had 80% completion of all 40 questions. And in the Q4 days study group, there was only 68% completion, and that came out as statistically significant. And then the other main result was that in both univariate and multivariate analyses, controlling for all of these different other factors, because it was like a very a broad global study, there was a baseline, no particular statistically significant difference in the baseline scores, but a completion, there was a significant difference in the completion rates in favor of Group A. But the actual difference was between 100% completion in Group A versus 98% completion in Group B. Overall, the data presents some guidance on how possibly to structure a gamified learning program. And it's interesting that, despite how busy all these staff are, more frequent emails were superficially more effective. But ultimately, there's a number of concerns that you can bring up with the study. The main concern I had was that the title advertises a space education game and it advertises itself as a randomized controlled trial, but there's no specific intervention-less control, just 2 intervention groups. I think it would have been a much more interesting question to answer to have a true control group without the gamified aspects, and that would give a better sense of whether gamification itself was the useful intervention. Furthermore, it wasn't apparent to me that the trial was pre-registered, and in an ideal scenario, all analyses would be pre-declared. But my other major set of concerns was related to the questions used in the study. They state that they've taken multiple reliability-related statistical tests, including a Cronbach's alpha for the 40 questions that they used. But ultimately, Cronbach's alpha and these other reliability tests, they're tests of internal reliability. All it tells you is whether the questions in a questionnaire appear to be measuring a similar construct and are generally aligned with each other. But ultimately, what we're really interested in is, are the questions useful? Are they externally valid? We have no idea whether the questions really measure the right construct. And maybe the right construct is a little nebulous, but, in my mind, ideally, it would be something aligned with improved clinical practice, better decision-making, medical decision-making in the real world. And there's no external validation to these questions. My other issue with the questionnaire is that it's not really built to assess whether there's a difference in learning effect. I feel like there's a very strong ceiling effect to the way the whole question delivery is set up. Because Group A got 100% and Group B got 98%. They're both right at the very top of the measurement. It's like measuring something that's 45 centimeters long with a 30-centimeter ruler. It's not hard when you have a multiple choice question and you're shown the same question again in a couple of weeks to just remember the choice and pick the right response. So I'm not surprised that the completion scores were basically all 100%. So I think it would have been more useful to use some type of more externally valid set of questions and then use a more difficult set of questions or slightly changed questions to tease out some kind of learning effect. A lot of effort goes into delivering a study on 1,400 people. So, I think these things would have been nice to see. On the point about the external validity of the questions, what would be particularly interesting was if the answering questions sent via email generally has meaningful and durable impacts on clinical practice. And the study that we just looked at isn't able to answer that, but other work from this author seems to suggest that might be the case. So this is a slightly older study about trying to get GPs to order PSA testing more appropriately. And it was very similar, actually, very email-based space recognition question set without the game elements, though. And it was sent to 95 family doctors, half of whom had the game and then half of whom didn't do the space recognition questions at all. And during the intervention period in the first year, we see that the clinicians receiving the email questions ordered significantly fewer inappropriate PSA screening tests than control clinicians, 10% versus 14% in that range over the first half year. And then the next year and a half on top of that, the spaced education clinicians continued to order fewer inappropriate tests compared to controls. And that was representing about a 40% relative reduction in inappropriate screening, which was a big deal. There were no gamified elements in the study again, but I think there's some learning point that can kind of be transferred over into our interpretation of the other study. Kerfoot's team has also applied the same spaced education game to do resident teaching, although this one was not part of a randomized trial. And then lastly, their team had also published a research letter or an abstract in JAMA Surgery, seeing whether gamification can get residents to spend more time on a Da Vinci skills simulator. Not too many results from this because it was just kind of an abstract, but over 14 weeks, to summarize what they did, they took urology residents and gen surg residents out of Brigham and Women's and then Boston University. And they told residents that for 7 weeks, they could use the trainer as much as they liked. And in 7 weeks, they were going to be starting a tournament where only the 16 highest scoring residents could actually enter the tournament. Basically, they were getting tested on 9 different Da Vinci simulator exercises. And then they also posted a public leaderboard every 1 to 2 weeks or so. And then the tournament itself had prizes ranging from $50 to winning an iPad, I think, if you got first place. And so the question was like, can gamification or introduction of game mechanics boost resident engagement? And the answer was ultimately yes. It seemed that it was more so effective on the urology residents overall. 50% of the urology residents that were kind of enrolled into this program actually started using the Da Vinci robot more when they were told about the tournament, told about the leaderboard, and then maybe only 10% or less of the general surgery residents were, getting involved. I think that makes sense, the limited uptake among general surgery residents, just given the less robotics emphasis in that specialty compared to urology. But overall, pretty interesting. Next up, we'll be taking a look at a more conventional game aiming to teach urology-related content to medical students this time. So this article is from the Department of Urology at the University Medical Center of Freiburg in Germany. Their goal was to teach phase contrast microscopy urinalysis to medical students. And to do this, they made this electronic adventure game called Uro Island. In this game, the player has to control and navigate the game character to explore an island on which you somehow got stranded. And you have to complete a series of quests to escape the island. And the series of quests are all each related to some series of urological pathologies. One feature of adventure games in particular, including this one, is the gathering of items and attributes to use in subsequent episodes of the story. So here's an empty inventory when you start, and then you accumulate some stuff in your inventory as you progress. And then, for example, in the left screenshot, the player character. So you're the guy in the white coat. You're with a non-player character named V6. And you have different things in your inventory like cells, crystals, and tools. And in-game, you can use them together with the correct devices up here, or like the microscope or the autoclave to proceed in unfolding the story of the game. I'm not sure why the friend that you're accompanied with is shirtless holding a bottle of beer, but I'm sure there's some narrative reason as to why that's the case. So the ultimate goal is to gain your freedom back by advancing the quests to a clear diagnosis and then to escape Uro Island. So the overall objective of the study was to compare the effectiveness on the learning outcome of this game-based e-learning intervention. And they compared that to a conventional script-based intervention in teaching, again, phase contrast microscopy urinalysis to undergrad med students. 145 German medical students moving into the third-year urology rotation, and they were randomized to either studying with the Uro Island game or the script. And the script is basically just an 8-page detailed document kind of outlining all the learning objectives. The outcome was purely single test performance on an end of rotation 34 question multiple choice questionnaire. And the type of trial itself is a randomized controlled trial where they undertook, as far as I could tell, again, a non-pre-declared analysis. And they described the analysis as a ITTAT analysis. That stands for intention to treat, adjusted for treatment. Supposedly, it corrects for non-compliance with the assigned intervention. They're not exactly clear on how that analysis was undertaken, but it appears to be distinguished from a per protocol analysis. Again, there off the bat, there are concerns with using a custom developed questionnaire, where even with the cursory internal reliability tests, there are limitations with whether answering well on a MCQ actually translates to meaningful clinical differences. Yeah. So here's a consort-based flow diagram. That's figure 1 of this paper, where we see that of about 145 patients assessed for eligibility, no one declined, and everyone was either randomized to the game-based intervention group or the script-only group, and that was their control. And they also collected a reference population to their credit, just 117 students, not trained on either modality, just to have as a baseline for how well people do generally. And then what they did was randomize students as they entered into their week-long rotation in random batches. So each week in the rotation, 3 to 6 students would get sent to rotate in the urology department, and that's when they would get randomized in batches. They didn't really make totally clear how they allocated the students to one study group or the other. They just said they alternated between intervention and control group. But it looks like there's some uneven allocation going on. 82 people were assigned to the game-based group, and then 63 people were assigned to the control. I kind of want to take this as an opportunity to discuss allocation. Aside from a bit of lack of clarity as to why it's uneven, whatever's happened, it seems to have resulted in an uneven allocation. And uneven allocation is not necessarily wrong or bad, but it does come with downsides. And some trials will even deliberately have uneven allocation ratios. But first, the obvious implication is that maybe that data is somehow missing. And they discussed missingness, so I don't think it's related to missingness. But if it is related to missingness or people kind of absconding from the study and not being accounted for, the implication is that maybe data is missing in random, which is obviously always concerning because it systematically biases the results one way or another. But the another thing is that even if you do account for everything, and that the data is not missing at random, having uneven data like this has a bigger impact on the study power of a study than even data losses. So losing or failing to accrue 40 people when all 40 are kind of lost from 2 arms equally is better than losing all 40 from just 1 arm. So yeah. Getting to the results, the means.
Sorry, can I ask just a question? Because you said it was a weird intention to treat, but allocated treatment. I'm not so sure. So it sounds like they didn't really do intention to treat. They just analyzed for what participant went to do. So that could have, just bias whether or not they've received that investigational gain or not.
Yeah, I agree. They were pretty unclear about exactly what they did. It just sounded like some kind of multivariate analysis where they somehow accounted for the fact that the amount of dropout was a certain amount in each group. So it's kind of this weird midline between an ITT and a PP analysis. Getting to the results, the means were getting 26 out of 34 questions correct in the script group, and then 29 out of 34 questions for the game-based learning group. And that was statistically significant. But again, without using some kind of externally valid testing scheme, it's really hard to interpret whether that's clinically meaningful. It's also an immediate post-training effect. And what would have really been particularly meaningful is seeing the real durability of the results. But the authors also conducted a nice survey at the end where they asked a simple 4-point Likert scale type questionnaire. The first question was, would you like more material like this in your training? The additional material question. The second question, which was called fun, is, did you enjoy working with the learning material? And the third question was about confidence. Do you feel confident in the domain of laboratory urinalysis now? And then for all 3 questions, we see that the group randomized to the Euro Island game ended up scoring 4s on the Likert scale, much higher, indicating they liked it in all of these 3 different questions. And the questionnaire is made up purely for the purposes of the paper, but it is reassuring to some extent that the uptake among students was as good as it was, and that the reception to the game was positive, because as we know, you have to actually enjoy the game to even engage with it. let alone engage with it in the long run. Last on our list for serious games for learners, with respect to this time improving trainees' technical skills. There's not much specifically in the domain of serious games for urology for specific surgical applications. We recall that neon conduit game for green light XPS procedures, but other than that, I'd say most of the literature in checking out in serious games for like technical skills is more so in the domain of general surgery or general laparoscopy skills training. So um, less critical appraisal for this section, I'd say. One of the more well-regarded studies in the space I wanted to highlight, I thought was cool, was this paper from Nickel et al., published in Surgical Endoscopy. It's from a group in Heidelberg University, and they developed this phone app called Touch Surgery. And then on top of that, they developed this VR trainer called Lap Mentor. And the aim of the study was to assess the transferability of surgical skills for the laparoscopic hernia module between the game Touch Surgery to this virtual reality lap mentor laparoscopy trainer. So they didn't actually see the carryover to real surgery again. So like not very patient oriented or clinically oriented, but still I thought it was quite interesting. If you're not familiar with the Touch Surgery app, it's actually quite impressive, and it's not just for abdominal procedures, but a huge variety of procedures, and it's getting updated quite regularly. And it takes people step by step through the procedure with 3D anatomical models and good explanations of the anatomical landmarks and things like that. Yeah, we see a screenshot of it off to the right where we see it's giving kind of a critical view of a hernia repair. And I was actually quite fooled by the Lap Mentor screenshot. I thought this was like real at first, and there was some Photoshop done afterward. But no, this is VR. So yeah, it's a pretty interesting training, VR training device. Another thing I wanted to highlight was that even though the Lap Mentor production value was quite good, the production value of this game is even better. So here we have this game called Underground. It's developed by this studio called Cutting Edge. It's out of the Netherlands. They made this in conjunction with a surgeon from a local teaching hospital. And in this game, you basically are trying to help a bunch of trapped robots in a mine escape the mine. And you can kind of see inside the mine and then manipulate objects within your view through two sticks that you see here and here. And the two sticks are actually just two Wii controllers strapped to the outside of a box at a pivot point. So it basically mimics a laparoscopy trainer, but it's all simulated. But instead of a simulated surgical exercise specifically, it's meant to be story driven and engaging. You're kind of like helping move these robots around and stuff like that. There are no formal studies on this particular topic of whether lap skills improve after playing this game, and the console itself, unfortunately, is outdated now, so this game isn't getting any further support. But I thought it was a pretty interesting application of a serious game in surgery. Now, serious games should also be taken seriously, not just for learners, but for patients as well. So let's now pivot and take a look at a serious game application in patient education, specifically for delivering urotherapy and motivating children dealing with incontinence. So here's an article published in the Journal of Pediatric Urology in 2019. It's titled, "Does a Serious Game Increase Intrinsic Motivation in Children Receiving Urotherapy?" The premise of the article is, well, one, urotherapy is the treatment of choice for children with daytime incontinence. Motivation and adherence are really important in urotherapy training. Games can improve motivation and adherence. So maybe therefore a serious game might improve motivation to engage with the urotherapy, engage with the training. It's worth going through how the game works before talking about the methods and results of the article. Otherwise, these screenshots don't make any sense. The game is called Lutz and the Leaky Cauldrons. The study authors got a professional game developer to make this for them. It's kind of this layered story where the child plays as this robot character that's leaking his oil, I guess. And you play as this character because you're trying to help rescue this kidnapped princess here, and you have to fight monsters on your way to rescuing the princess. The game is like really quite developed, but I'll distill the key points. you're trying to rescue that princess while your character has issues with urinary leakage. Part of the game involves filling out a voiding diary in game digitally and then keeping up with certain voiding habits. And then as you fill out the voiding diary, you get extra lives and you get extra coins and also written compliments. And then at the end of the game, the princess tells you to hold on to the good habits that you built up. So overall, the link between the actual gameplay of fighting monsters and urotherapy is a little bit tenuous, but there's a connection there where the child who's playing keeps up the voiding habits, they get positive reinforcements in game. It helps them in the game. And if the game is fun to them, then they have to learn how the voiding training works in real life to finish the game. To formally describe the study, this was a non-randomized study where 50 children aged 8 to 14 with daytime incontinence were allowed to choose among receiving bladder training so that was the intervention group, bladder training with standard therapy, or without the serious game, so just the standard therapy. So that was a control group. And then at 4, 8, and 12 weeks of training, the children and parents were asked to complete an intrinsic motivation inventory. And then the children also completed the PIN-Q questionnaire, or the Pediatric Urinary Incontinence Quality of Life tool. And again, they did that before the start of training, and then it's 6 months after. And then at a 6-month follow-up, the patients also participated in focus groups where the children kind of discussed just more in terms of qualitative analysis, like how they use the serious games and which improvements they would have liked to see in the game. So off the bat, we're moving into the realm of actually using externally validated, reproducible questionnaires with real clinical meaning that can be portable from study to study. And that's super important. Some people might bridle at the fact that the patients selected their own research group, but I actually find this really refreshing and highly pragmatic. Realistically, if you're offering somebody a game, they should be allowed to pick up the game that they think they like it. And then what they like, they should be able to reject things that they don't like in terms of the actual resources they want to engage with. Playing games is super personal, and what one person finds fun, somebody else might find a boring nightmare. So I think it's really important to closely mimic as possible the real circumstances under which anybody would actually ever interact with the game. And then finally, there's a 6-month-long follow-up. And so there's interest in these authors in actually assessing the durability of the study result, which I've been saying for a while is quite important for study design in this space. Looking at the study flow, nearly 90 people were initially agreeable to participate, but only 50 people ended up actually being enrolled. Certainly at baseline, I get the impression that this is probably a more motivated set of kids and parents. Overall, to summarize the results without getting bogged down by the tables, the children who received standard bladder therapy or training with the addition of the serious game, they did not differ in terms of the intrinsic motivation on the IMI questionnaire from children who just went through the standard therapy only. And clinically speaking, the training results were equal in both groups. So 80% of people in either group basically saw good or improved outcomes in terms of their PIN-Q score. And then incontinence-related quality of life changes between the groups were also improved in both groups, basically the same amount. So overall, the study was negative. But oddly, the reception to the game from the children was actually fairly good. And they overall found it an attractive teaching tool. And in particular, the older participants who elected to play this game, they specifically asked for more disease-related facts to be included into the game. So I thought that was interesting because they're only like 14 years old at most. So yeah, it gives some insight into what priorities kids have. Lastly, I want to discuss a serious game that seeks to help older men with prostate cancer decide what therapy might be right for them. So not all serious games evaluation needs to be quantitative research. And indeed, this paper is more on the qualitative side of things. This is an article published in the Journal of Medical Internet Research about a serious game that's built to help men dealing with localized prostate cancer titled Assessing the Acceptability and Usability of an Interacting Serious Game in Aiding Treatment Decisions for Patients with Localized Prostate Cancer. As we know, there are multiple treatments that men can elect for in this domain, including prostatectomy, brachytherapy, external beam radiation, watchful waiting. And the authors wanted to include all of those. They called their game Time After Time. And the point was to guide users through a simulated experience of the common impacts on a health-related quality of life over the short and long term to help them determine which treatment strategy would be most acceptable to them based on their personal preferences. Um, Looking at the pictures, it doesn't look like much of a game, but to help explain what's going on, the game is divided into rounds where you explore each of the main treatment options I just mentioned. And then the more immediate side effects are presented for each treatment option, and then the player has to rate each of the side effects in order. After the user has rated the side effect cards in all four treatments, in the time period immediately following treatment, they're introduced to the spinner screen using another guided orientation round where using slot machine-like imagery. So you can see that in the screenshot on the left. The spinner screen kind of graphically displays probabilities of different side effects in 5 different domains. The side effect profiles are based on the Expanded Prostate Cancer Index Composite, or EPIC. It's a landmark tool to measure health-related quality of life after prostate cancer treatment. And itself, that's based off of a large prospective multi-regional study. So in that sense, critiquing the game itself, in this regard, it's actually giving fairly nicely validated and reliable information to patients with respect to the side effect profiles. It's based on some really high quality data registries. So to kind of summarize PICO a little bit more, there were 13 men that were enrolled. They had already completed treatment for localized prostate cancer before getting enrolled into the study. And specifically, all of the patients were recruited from this local prostate cancer support group in Houston, in Texas. In some sense, I think that kind of self-selects for a population that's already quite a bit more likely to be engaged with this type of outreach type work from doctors, especially if they're already involved in the support group, right? And so that might make them more receptive at baseline to the efforts of the game developers, and maybe they're not fully representative of the average person who's presenting with localized prostate cancer. The paper was mixed methods in nature. There was no particular comparator, although they did have custom developed Likert scales again to have a more quantitative angle on things. Now, this isn't all of the questions that they asked, but I didn't think it was particularly necessary to get bogged down in all 24 questions. Overall, again, the study developers developed this customized questionnaire, and they generally found that most men kind of engaged equivocally with the outcome, with the game itself. So the funny thing is there are actually several validated questionnaires in this particular space for evaluating the utility of a new internet-based or computer-based medical resource. So I thought it was a bit strange, again, that they developed their own questionnaire to all this, but they did what they did. One thing I felt was interesting as well when looking at this Likert questionnaire is that the study authors placed the strongly agree box off to the left. I don't know if this might not be all that well known, but in Likert scale-based questionnaires, there's often a well-documented primacy effect where people are generally more inclined to pick things closer to the beginning, off to the left. Anyway, looking at the questions, they're appropriate overall. So for example, question 1 is, if this was available at the time of my diagnosis, the interactive website would have improved my confidence, or the interactive website is useful, which seem fairly face valid. The paper itself comments quite optimistically on the responses to these pretty straightforward questions. But when you actually look at the data, I'd say that these straightforward questions don't really have the most favorable responses from the participants in aggregate. So for example, in question 1, more people in the study actually disagreed that this intervention would have improved their confidence when making decision-making for prostate cancer. And then they were also really equivocal about whether the interactive website was useful. So, you can see that the confidence interval kind of touches the midline at 4. Other questions had more favorable responses, but they don't really relate necessarily to the game itself, strictly. So for example, one of the questions is, an interactive website is effective for providing information. And of course, the answer is going to be more inclined towards agreeing. But yeah. So on the basis of the more qualitative aspect of the study as well, I'm not going to put up too many quotes on the page, but the men enrolled understandably found the game acceptable, but perhaps not as usable as is required for that population. Because you can see that in question 5, the instructions are sufficient. Again, they weren't like totally in agreement that the instructions were necessarily useful. And even looking at the screenshots, it's kind of confusing as to what's going on with the game. So in conclusion, overall, my impression of the space of the game of the space of serious games in urology is that, perhaps the whole situation of serious games is a bit of a solution that's kind of looking for a problem. I think good e-learning design starts with understanding the pedagogical issue and then understanding then what the most appropriate technology might be. And oftentimes, a game is just not the most effective way to deliver learning. And effectiveness is not just efficacy, but how something really works in clinical practice. And if you can't dedicate the resources to make a sufficiently compelling or high quality game, then the uptake is going to be poor, or the game just won't be especially good as a learning tool. So sometimes it feels when you're reading papers on the space, it feels like somebody's asking, how can we use a game here? But maybe the question should be, what is out there that is hard to teach? And would a game be the most appropriate technology? Which is not even to mention how hard it is to make a good game. People put in a ton of work in developing these serious games. And what's really, really difficult again is, I have mentioned earlier, one person's sense of fun is really another person's nightmare. Even for fun, regular games, the same people who like role-playing games, for example, might hate sports games and vice versa. And they're both fine games, but, different strokes for different people. And you can't reach everybody with any particular game. When it comes to gamification, I think there's more promise in that space in particular. Adult serious learners engage well with the resources they already have at their disposal. And it seems like when you kind of take a look, from sky high, about gamification of things that people already engage with, gamification tends to help. Like residents engage more with surgical skills training, or anybody can engage better with CME. But developing actual full games, I think we're still waiting on that killer app to come out. And there's a huge cost for making and implementing these games. And overall, it seems like the slope of the quality price curve where games are situated is rarely favorable when it comes to delivering medical education. But occasionally it is. If you think about the neonatal resuscitation simulator, again, that's a high acuity, low occurrence situation. It's hard to train that in other settings. And so developing a VR game, even if it can be expensive, you can see the benefit from that. And it's not just making the game that is difficult, but even studying them in a systematic way. The space is so heterogeneous and it's difficult to do real meta-analysis on. The game implementations are just very, very different, as you saw. And the use cases are also so different. Some of the games, some of you guys might barely call a game, and other ones are obviously much more gamey, but again, they're not really studied deliberately. But when they are studied deliberately, the studies, in my opinion, need to more often use real clinically interesting outcomes with real carryover to clinical practice, and to the best of their ability, see if there's long-term durability of any of the results. So yeah, that's about it. Thank you all for listening. Are there any questions?